Our next speaker is a good friend and colleague of mine. We first met and collaborated as far back as 1996. And at that point, he was an excellent font of knowledge and advice. And 20 years later, even more so. So he's going to talk to us about the clinical situations and how imaging has altered his treatment decisions and recommendations. Over to you, Anwar Padani.
Thank you, Vincent. Good afternoon, everybody. These are my disclosures. Now, we all know that patients' needs change as patients progress along their pathway. We've heard something about suspected cancer today. We've heard something about biochemical recurrence. So what I'd like to do is start by looking at low-risk disease. In low-risk disease, prostatectomy specimens show that a substantial proportion of patients have high-grade cancers that you don't even know about. And if you look at radical prostatectomy specimens in patients who are potentially AS candidates, if you look at pathology of these specimens, you'll notice that you are underestimating risk in a substantial number of patients, and the literature shows it's between 20 and 40%. So the instruction that you should give to your radiologist is to confirm that the patient truly has low-risk disease. The second instruction is, if it is not low risk, where is the high-risk cancer? And the third is, if you're going to be planning surgery, is can I do nerve-sparing procedures on this particular patient? Now, the type of examination and MRI that the radiologist will perform will depend on those three instructions. So you have to be very clear when you refer your patients to your radiologist, because his protocol can change. Now, it turns out that there are a number of imaging features on univariate and multivariate analysis that can predict for bad pathology. Essentially, if it looks bad, it is bad. So we've talked about the PIRADS system. If you have a PIRADS 4 or 5, these patients should not be undergoing active surveillance. So here is a patient who is a PIRADS 1. We know there's a cancer, 5% of cause on the left. This MRI is completely normal. It's called a PIRADS 1. There is nothing to see. This patient is very suitable for active surveillance, and you can see that his last active surveillance scan was ES7 in 2015. On the other hand, as far as you are concerned and your trust biopsies, this patient is also suitable for active surveillance. But the fact is, in real life, he's not. Why? Because he's one of those 20 to 40% of patients who has a large tumor anteriorly which has not been sampled. This is precisely the sort of patient who should not be going active surveillance. This is the type of patient you should be treating with either surgery or radiotherapy. And this is part of my job. My job is to tell you that this patient is not suitable. Now, what are we going to say about this particular patient? This patient is a PIRADS 4 lesion. It's 7 millimeters in size, but it shows all the characteristics of a prostate cancer. All the characteristics. Okay? It's classified as PIRADS 4 because it's less than a centimeter and a half. Is this patient suitable for active surveillance? So, you've got your voting pads. I've noticed that none of you have used it so far. So, is this patient suitable for active surveillance? 1, yes. 2, no. 3, borderline. Please vote. Okay, you're out of time. Let's see the results. Okay, so yes, no, and borderline. Roughly 1/3 each. Okay, good. Now, if you look at treatment-free survival, according to the PIRADS classification, then you can see that PIRADS 1, 2, and 3 clearly separate from 4 and 5. Clearly separate from 4 and 5. So this is the first lesson to take away, that if you have a lesion that looks bad and has a higher PIRAD score, you should not be doing active surveillance on this patient, or you should be watching him very carefully because he may have a lesion that could do him harm. Now, the interesting thing is this is preliminary data and we need to confirm this, number one. Number two, the PIRAD system is not validated for active surveillance. The PIRAD system, as you have already heard, is the ability to detect tumors. Yet, we are beginning to use it in active surveillance. If you look at the guidelines, there's only one guideline that really comes down firmly on the use of MRI, and that's the NICE guideline in 2014. The NICE guideline says that you should do a multiparametric MRI before undertaking active surveillance to detect those 20 to 40% of patients. And secondly, if something changes, you should repeat the MRI. Now, these are the kinds of changes that you will see in patients. Now, here is a patient who has a small lesion in the right peripheral zone. This lesion here, tiny, tiny, tiny little lesion. Okay, 3 plus 3, 5% of cause on the right, no cause on the left. Now, he gets instrumentation. This is a bladder catheter, instrumentation. Look what happens to the peripheral zone of the prostate. Can you see that? On the T2 sequence, he gets new soft tissue abnormality in the peripheral zone. On the T2, and you see the same thing on the diffusion scan. So here is the diffusion scan. Again, we see a change from white to dark. Can you see that? Now, this is benign. That's why not all high PIRADS lesions are malignant. If you have a PIRADS 5 lesion, 80% of times they'll be malignant. They can look like cancer, but only 80% of times they're malignant. If it's PIRADS 4, it drops to 60%. Remember that. Okay? So everything that looks like cancer on MRI isn't necessarily cancer. Now, look at this particular patient. This patient changes very subtly on active surveillance. If you look over here, this is the cancer. Here's the peripheral zone at the base on the right. Here it is on the left. And look what happens a year later. Can you see there's an increased bulge? You can't see that, can you? I can see a doubting face at the front. You can't see it. Even I didn't see it prospectively. If you look at the diffusion scan, it doesn't change. But on the dynamic contrast enhancement, you have a light bulb. A light bulb switches on. Hang on a minute, something changed. That change should prompt you to re-evaluate this particular patient. Get a targeted biopsy from that area. Targeted biopsy using a template technique, 3 plus 4. The patient went to prostatectomy, 4 plus 5 plus 3, correct? Plus T3A disease. Remember, this patient was active surveillance. This is precisely the sort of patient you want to find. Early monitoring, this guy is dangerous, get him definitive therapy. That's what MRI is there to do. In fact, this whole thing has been taken up by what's called the PRECISE group, and Peter Carroll was on this group as well. Now we have a Likert scale for change in the MRI. So what we'd like you to do is to go away, do active surveillance patients, grade the patients according to the Likert scale, and then report back to us in 3, 4, 5 years about what your experience is. Now, if we talk about intermediate risk patients, intermediate risk patients have a 5-year disease-free survival of 2 to 70%. 2 to 70%. This is a big bucket because if it's not low risk, it's not high risk, it gets shoveled in the middle. Duh. How can you guys triage patients on the basis of treatment-free survival of that sort of thing, progression-free survival of that? Well, do imaging, because this and this patient are both intermediate risk. except this is the cancer here, and this is a cancer here. This is 4 plus 3, this is 3 plus 4, right? So imaging can tell you whether a patient is in a favorable category or an unfavorable category, but we radiologists have still not agreed on the criteria for what is considered favorable and what is considered unfavorable for intermediate risk prostate cancers, and this is a job that radiologists still need to do. Now, the risk, whether a lesion is favorable or unfavorable, affects your treatments. So if you have an unfavorable subgroup, in other words, predominantly Gleason 4, large amounts of tumor, a bigger volume, or more than one of these factors, then more than likely this patient needs a staging MRI because you're going to go for some sort of cure, surgery, radiotherapy, adjuvant, hormonal therapy, etc. Now, so here is an example of that kind of approach where a lesion was treated with a focal boost and high-dose brachytherapy. Okay, now, if you think the patient may be favorable, then the type of MRI I'm going to do is going to be different. You see, here I would do a staging MRI, here I would do a characterization MRI, and the criteria that I use will be different. Will be different. So you need to tell me where you think this patient is. Now, if we do an MRI, if I see no adverse features, then some of these patients are suitable for active surveillance. And you look at your own guidelines. Your own guidelines say that there are some 3 plus 4 cancers that are suitable for initial active surveillance. Now, if you did an MRI scan and you saw nothing, and here is an example of just a little bit of shading in the right peripheral zone, there's no mass here, but it's 3 plus 4, you could try initial AS in this patient if you wished. Okay, now what happens if you have a patient who's showing some feature that suggests that there is not quite intermediate risk, that this may be unfavorable? Look at this particular patient. This patient has got Gleason 3 plus 3, but his PSA is 17. So all of you can sniff a rat, right? You can smell a rat. There is a rat here somewhere. Okay, do the MRI. Where is the rat? Well, hang on a minute. There's the rat, a big tumor, Gleason 3 plus 3, biopsied 3 times. But this is a rat. This is a large Gleason 3 plus 3 tumor. This is the sort of patient that does not go on active surveillance, because you can see it's a large volume Gleason 3 plus 3. This is precisely the information that you need to be able to triage your treatments. And in this particular instance, he got HDR with a focal boost. Okay, so many of you are surgeons and you want to cut, okay? In intermediate risk, you want free margins and nerve sparing if possible, right? We know that the prevalence of extracapsular disease in intermediate risk is roughly 20 to 30%, right? You want negative margins, okay? The criteria that we apply depends on what you do, on what you are going to do to a particular patient. So you have to ask that specific question, okay? But how good are we at telling you about extracapsular disease? Well, the answer is not very good. Not very good indeed. And you've heard this already. So this is extraprostatic disease and the ROC curve. You can see the specificity is quite high. It's over 80%. So if you have an average radiologist as a colleague, right, who's over there, that's the average radiologist, you can see whether he's a great radiologist or a poor radiologist, his specificity will be high. So you should believe him. If he says the disease is out of the prostate, he's going to be right 80% of the time. You should believe him. If he says, I think it's not out, don't believe him. Don't believe him. So if he says it's out, believe him. If he says it's not out, don't believe him. Why? Because of the spread of sensitivities. So you may have a superb radiologist. Well, he'll be up here. You may have an average radiologist who'll be up here. You may have a radiologist who's doing this for the first time. Well, he's going to be down here, and you certainly shouldn't believe him. So if you have an average radiologist, don't believe him. If you have a superb radiologist, okay, then it depends on what is your plan. Okay? So that's the importance of being very specific about what you say. So let's look at this patient. Intermediate risk, large anterior tumor. This is a PIRADS 5 lesion up here, and I'm going to ask you the next question. Don't look at that prostatectomy specimen. Okay, can this patient have nerve-sparing surgery? Big lesion, anteriorly, there's the index lesion. Can this patient have nerve-sparing surgery? Yes, no, or you're a radiotherapist and you don't know. Okay, let's vote. Come on, Bertrand. Hey, well done. So most of you are surgeons, yes? I take it. Okay, so 66% said that this patient can have nerve-sparing surgery. Why is that? Because the tumor is located. Can we switch to the slides, please? Because the tumor is located anteriorly. The index, you can see it's multifocal, but the index lesion is anterior, and of course, your neurovascular bundles are at the back, and you can see we did nerve-sparing surgery. Now, what do the guidelines say? The guidelines say that multiparametric MRI may help decide whether to perform nerve-sparing procedures in intermediate and high-risk patients. The question I'd ask you is, where is the evidence for that guideline? Well, it turns out that the evidence is not very good at all. It's in the recommendations, but the evidence is not very good. So, if you look at this paper, which has already been reviewed today, you can see that positive surgical margins in nerve-sparing surgery, whether you had no MRI or you had an MRI, were not different. Exactly the same. But look, in this case control study, no MRI and no intraoperative frozen section at the site of the MRI abnormality. Again, similar statistics. But if you do an MRI plus intraoperative frozen section at the location of the index lesion, you can see that nerve-sparing surgery and positive surgical margins go down significantly. So the bottom line is, look at the MRI. If the MRI shows you an index lesion, you need to focus on that area during surgery, do whatever surgery you need to do, including intraoperative frozen section at that site, and you cut, and you cut, and you cut until you get a negative margin. At that point, if you act on the MRI information, your your positive surgical margin rate will go straight down, 5-7%. And that's what many centers in the UK are certainly doing. I just wanted to spend the last 10 minutes on high-risk disease. Now, at high-risk disease, we're really talking about staging. You guys are interested in knowing nodal status and bone metastasis. Nodal status, don't ask me. But all I'm saying is, don't ask me, because I'm not very good at this, right? You know, that's it. We are using size and we suck, okay? So that's it. And that's exactly what you heard. PSMA PET, I think, will be better. Choline PET, okay, right? But I'm sure PSMA PET. But I'm here to talk about something you can use today, not in a few years' time. Okay. Now, as regarding metastatic disease, what do the guidelines say? The guidelines say the bone scan is recommended in particular circumstances, and I've just put them over here. Essentially, it says, it gives you guidelines, but it doesn't address the issue of, the guidelines do not address the issue of bone scan insensitivity. Okay, so look at this. So here is a locally advanced carcinoma involving the seminal vesicles, high risk. Here's the planar bone scan, and these are some spot views. You can see the spot views here and here. Okay? Now, this is one of your patients. Is this patient got metastatic disease? Yes. No. Only T3B disease. Maybe get a plain X-ray, because that's in the recommendation. Or maybe get an MRI scan to clarify. Okay? Why don't you vote now? 1, 2, 3, and 4. Yes, this definitely is metastatic disease. This patient is, no, it's only T3B. Get a plain X-ray, guidelines, or maybe get an MRI, a proper MRI to clarify. What do you think? Whoa, good. So a few of you say that there is definitely metastatic disease, and some of you would like an MRI, and nobody would take a plain film. Thank you for coming to MRI after all this time. Okay, let's go back to the slide. Now, so here is a whole body MRI scan. You don't need to do a whole body, but we do whole body whenever there is a risk, and you can see this lesion here in the femoral head is in fact a fracture. We can say for sure this is a subcapital fracture, forget it. This is not metastatic. Okay, and in fact, there was a very good study in high-risk patients which Professor Tombal took part in and basically showed the same thing. I don't want to go through this data, but what I did want to show you was a meta-analysis. So this is the meta-analysis. It's horrible to see numbers like this, isn't it? It's just impossible to digest these things. So let's look at an ROC plot. If you look at an ROC plot, this is MRI. This is PET scans. This is bone scans. Right? What do you guys do? That. What should you be thinking about doing? Maybe that or that. It's as simple. Now, in 2016, you need to think about refocusing. Maybe just put that little thought in your mind. Certainly, in our centers in the UK, there are a number of people who are now doing whole body MRI for this particular purpose. Okay, so some of you will say, yes, okay, bone scans are not great, but what about disease monitoring? Well, let me show you a patient who's receiving ENZA. So this is a MRI scan. It looks like a PET scan, I know, but it isn't a PET scan. This is a MRI scan. This is an MRI scan. You can see retroperitoneal lymph nodes. Here is the bone scan, which I'm sure all of you recognize. You can see this patient has a good PSA response. These retroperitoneal lymph nodes get smaller. Everybody's happy? Good. Gets another 12 weeks of ENZA, and I see a lesion. See that? Some of you are going, I can't see that dot. Well, the advantage of MRI is that you can get additional images in any spot in the body. Any spot in the body. And this lesion here is a metastasis. There it is. How do I know? Because it wasn't there 12 weeks ago, and it wasn't there 12 weeks before that. This is a new lesion that has appeared. What do the guidelines say? The guidelines say, ignore that, go with this, right? Okay, so what do? We keep treating. Another 12 weeks goes by. We see 2 lesions on the bone scan, but we see 1, 2, 3, 4, 5 lesions on the whole body MRI scan. Has this patient progressed? The answer is no, because a bone scan abnormality needs to be confirmed. Okay, then he gets another 12 weeks of treatment, and now he's got 1, 2, 3, 4, 5, 6, 7, 8, 9, and look at these lesions, we have now confirmed them. Okay, the problem with this way of working is that the actual date of progression was 25 weeks. The documented date of progression was 50 weeks, right? 24 weeks of treatment that wasn't working. Just think about that, okay? And what do you record in the notes? That's what you record in the notes, that this is the date of progression, okay? This is the Prostate Cancer Working Group 2 criteria. So I have to raise this with you. Is this really acceptable in the 21st century? Some of you will say, but I always use CT scans as well. I never use a bone scan. I've had question after question about this. Well, let's talk about that. CT scans, great for nodal disease and soft tissue disease. For bone disease, I would be very careful. Look at this. So here is a patient who's getting better on ENZA, okay? No doubt about it, on the bone scan, there's been a good PSA response as well. Look what happens on the CT scan. You have a lesion that emerges. Can you see that? Lots of my colleagues would call this progression. These are my colleagues, will call this progression. But you know it's response. The problem is, radiologists get confused by this pattern versus this pattern, right? This is progression. How do I know? Well, the vertebral bodies are collapsing. There's more disease, the PSA is going up, and the patient is symptomatic. I think this patient's getting worse, correct? But that pattern and the previous pattern often gets confused because radiologists cannot be confident about sclerotic progression and sclerotic response, okay? So how can you make things better? Well, you should do an MRI. An MRI can be tailored to look at the bone marrow, and you know what? You can do a detection whole body MRI scan on modern machines in 30 minutes. 30 minutes. This, look, I've actually written down the times it takes for all these sequences. This whole sequence takes 57 seconds. 2 millimeter cuts through the entire body in 57 seconds. Okay? If you have a good quality machine, you can do this in the clinic. We have criteria for response. We have criteria for progression. But we also now add diffusion imaging. And I tell you why we've added diffusion imaging. If you look at this patient who is responding, this patient is responding. You can see the PSA drops. You can see these residual scars. So when lesions respond, they leave scars. When they leave scars, on morphology, we can't say whether it's better or worse. We just can't. And that's called arrested resolution. Diffusion imaging enables you to be able to prize that apart. And you can see in this particular patient that the patient gets worse. From here to here, you can tell the patient's got worse, right? Got more lesions, gets better, better, gets worse, gets better. Easy. A policeman can do this, right? A policeman can go, you know, worse, better, better, worse, better, right? That's why we do this, right? Here's another example of a patient with a morphological scan that looks worse. Look at that, that, and that. There's less fat in the bone. The T2 image doesn't change, but the diffusion is like chalk and cheese. It's so obvious. It's right there in front of your face, okay? Why do we see that change? If you kill cells with chemo, with radio, whatever, if you kill cells, water molecules move more. If the water molecules move more, the diffusion signal falls. It's very simple. This is not rocket science. So, what do the guidelines say? Well, the guidelines, as we know, are always out of date. Here are the guidelines from the European Consensus Panel, bone scans and CT scans, the St. Gallen Consensus Conference, bone scans and CT scans, Prostate Cancer Working Group 3 for clinical trials, bone scans and CT scans. So, the radiologists decided to write their own guidelines because we think you should be doing whole body MRI scans. And this is the new guideline for using whole body MRI scans for response assessment and disease detection in advanced prostate cancer. Why are we doing this? We are doing this because we want a paradigm shift. What you guys are doing at the moment is this. The old way, current way, of looking at bone disease, all radiologists can say is there is progression or no progression. 2 categories. That's it. 2 categories. That's all you get at the moment. If you start using new technologies, then you cause a paradigm shift. What happens is you break the bone disease category into 3 categories. By shifting from 2 categories to 3 categories, you guys will think differently. If you think differently, you might even start acting differently. Thank you very much.
Thank you very much, Anwar. That was an excellent dissertation of the clinical scenarios. We are running quite short of time at the moment, but the wonderful thing is Professor Anwar Padani will be here with us until 5 o'clock tomorrow afternoon. So if there are any questions you'd like to ask, we have a tea break, which I'm sure that you're all wishing to attend, and he can be attacked then. So
Thank you,
I hope that's okay. Thank you very much for your participation.